Intracranial dysfunction, part 3. So when we say a tonic-clonic seizure, tonic and clonic are actually two different parts, the extension and the flexion, that then the child can go between, will go between the two actions. So when you're caring for a child who has a seizure, it's important to remain calm. The most important thing is make sure the child is safe. If they're sitting or standing, ease them to the ground so that they don't fall. Make sure there's nothing around them that they're going to hit. You want to time the seizure. And I would say it's best to write it down, because in a seizure, what feels like 10 minutes was 2. And I mean, you just really lose. That's true in any emergency, right? You just lose perspective of time. So, you know, if you've got a stopwatch on your watch or whatever, somehow make a good timing, because you're going to think it's way longer than it was. If they have clothing or jewelry or anything on them that can get caught or twisted or tightened, we want to loosen that. The best choice is that placing them on the side lying recovery position, and make sure that their airway is open. We're not going to restrain them. If they're having a tonic-clonic seizure, you're not going to be able to restrain them for one. Don't try. Just make sure they're safe. Don't put anything in the mouth. It's been decades since anyone recommended that, but that's still one of those old wives' tales that's out there. You really can't get anything in. They tend to clench down, and there's nothing you can do but injure them. Document how long the seizure lasts. So this is why you've got to stay there and time it. Document what you see, the movements, anything else. Did they have color change? What was their respiratory effort during it? Incontinence is very common. They lose sphincter control. And after the seizure is done, particularly those tonic-clonic seizures, often they are exhausted afterwards. So that's that post-ictal state. So document all those things. Stay with the child until they regain consciousness. At home, what we usually tell people is to activate emergency medical services if a seizure is greater than 5 minutes. Most are not. Most are shorter than that. If it lasts 5 minutes, now we worry about status epilepticus, and so it needs to be treated. Febrile seizures. This happens in our young kids. Peak age is 12 to 18 months. Can happen up to about 5 years, but it's really rare after that. They have a fever, right? But don't put them in a tepid bath. It's really not going to help. It can cause shivering, which makes their temperature go up more. Why some kids have febrile seizures, we don't know, but it seems to be related to kind of the speed that the temperature goes up, not so much how high it goes to, but how fast it goes up. So give them antipyretics. They don't usually put these kids on seizure medicines, and they rarely have them once they're a little older. Hydrocephalus. We talked about this a bit earlier. This is too much CSF compared to the absorption. So it's just building up. So we're going to see increased intracranial pressure on an infant because things aren't closed yet, right? The fontanelles and the sutures. You'll see increased head size and loss of developmental milestones or change in personality. For older children, this usually requires surgical intervention to put in a shunt to get off that extra CSF. So, and here's some pictures, horrible pictures of heads that weren't properly cared for. So when a child does have a VP shunt, one of the problems is the shunt can get infected or it can quit working. If they've just had it put in, we're going to place them on the unoperated side, and post-op, we want the ventricle of the brain that's full of CSF to come down, but we don't want it to come down so fast that everything inside the brain shifts, which can actually tear vessels. So we need it to come down slowly. The old days, we used to actually have a little thing on there and we'd pump the shunt. It had like a one-way valve, and they'd say so many pumps every hour. Okay, they're all electronic now. They can come and bring a little sensor thing, magnetic thing, and adjust the flow because we want to take that extra fluid off, but not too fast. So they're going to kind of slowly increase the amount it comes. And I had that picture earlier of the externalized drain. If that shunt's infected, we probably have to take it out, but we still got to keep getting the CSF off. So they'll do the internalized drain, treat them for infection, and then when it's ready, put in a new shunt. Here's another picture of a internalized shunt. And as I said, they usually try and leave a whole bunch so that as a child grows, it just stretches out with them. So signs and symptoms of a shunt infection, well, changes in the vital signs, especially running a fever, poor feeding, right? That increased intracranial pressure makes you nauseous, vomit, decreased responsiveness can cause seizures. And then if the infection is along the track of the shunt, you'll see inflammation along there. Craniosynostosis. This is when the sutures close prematurely, and basically they do surgery, go in and just break it apart, and the children do just fine. Positional plagiocephaly. This really wasn't a problem until the Back to Sleep campaign to combat SIDS, and the Back to Sleep campaign has been great. It really has lowered SIDS. The problem is people are afraid to put babies on their tummies. We need tummy time while the baby's awake. If the baby does nothing but lay on the back of their head, and especially if they like their head to one side all the time, they get a funny shaped head, and that's what this is. So babies need their heads different ways. We do want them sleeping on their back, but tummy time and other positions when they're awake. Bacterial meningitis. This is an acute inflammation of the central nervous system, of the meninges that cover the brain and spinal column. Back when I worked at the hospital, this was one of our more common admits. There was always a few kids there with meningitis. Since that Hib vaccine, we see a lot less. That was the most common germ in children under 2, and now we don't see it. We still see some meningitis, but we see a lot less, and we don't see that Haemophilus. So it can be caused by other things, though, like strep pneumoniae, Neisseria. This is kind of the really bad one. People will call it meningococcal, is the Neisseria. And so that's the one we want to, well, anyway, all of them we want to treat, but that one, just hours can make the difference in the outcome. Group B, strep, listeria, especially, children, that seems to be an NICU problem every so often. And then E. coli, which that's rare after infancy, but we can see that too. So lots of different germs. I was saying meningococcal, right? Neisseria infection is bad. It tends to do this damage to the extremities. They get this purpuric rash, and as I said, a couple of hours can make a difference in the outcome. So clinical manifestations of bacterial meningitis. We're going to see it's bacterial, so things usually come on abruptly. Fever, headache, vomiting, altered sensorium, right? That change in level of consciousness, seizures, nuchorigidity. If you bend their head forward, it hurts like crazy. And that's that Koenig sign. Their photophobia, they don't like light because they have such a headache. So labs, what we're going to see, the test for this is to do that lumbar puncture. They'll do a culture and sensitivities, right? So we'll put it on the petri dish and let it grow, and every 24 hours look at it. But what we're going to see immediately when they just look at it on the slide under the microscope, or run it through the machine and get a count, we're going to see high protein and low glucose. And your body sends white blood cells to try and fight it off. For bacteria, are polynucleated. The neutrophils are the first best ones that come out after bacteria. So high protein, high WBCs, especially the polys, low glucose. And if we have the serum glucose, so we can be sure the kid's not just hypoglycemic at the time, that's better. Right. And in an infection, that inflammatory process, everything kind of, your capillaries kind of spread out, and you get leaky capillaries, increased capillary permeability. So we get some cerebral edema from this, and it interferes with the blood-brain barrier, although infants under 3 months don't really have a blood-brain barrier very well anyway. We're going to also do blood cultures because often the organism's in the bloodstream as well, and that's how it got to the brain. So the treatment, we are going to put this kid on respiratory isolation because it's spread by droplet. Once they're on antibiotics for 24 hours, we can stop that. But the most important thing is IV antibiotics. That's the only thing that's going to kill the germs. So as soon as those cultures are done, we want the IV antibiotics started. We're going to do things to try and reduce that elevated intracranial pressure. So things that make them upset, don't do. The bright lights hurt, loud noises, they have a headache. So calm, quiet room. Bring the temperature down. Their seizure threshold is probably lower right now, so we want to control or prevent seizures and do good neuroassessment so we can see if that level of consciousness is changing. So how do we prevent this? Well, vaccination, meningococcal vaccination, H-flu, that's for our younger kids, and pneumococcal. So vaccinate. Aseptic meningitis. So this is not bacterial. We usually call this viral meningitis, but our book kind of uses the term aseptic. Anyway, so this is usually a virus. People are miserable, but we just treat the symptoms and let it run its course. This is usually oral fecal transmission, so it's not airborne, but somebody had the germs, put it somewhere, and it got ingested. And so less common causes, some other viruses like measles, mumps, herpes, HIV can also do it. Symptoms are less severe, but they are quite severe. People are pretty miserable. It will run its course. The symptoms will subside spontaneously. When you look at the CSF, you'll have a lot more lymphocytes, mostly monos, and you won't see such a high protein and low glucose. So treatment's just symptomatic. Encephalitis. This is inflammation of the brain, and this is so, frustrating of a disorder because most of the time we don't know what caused it. It can be a virus, it can be an autoimmune thing, sometimes vector-borne, so mosquitoes or ticks. Sometimes they improve afterwards and sometimes they don't. So onset can be sudden or gradual. They get malaise, fever, headache, stiffness, tremors, seizures, and it can progress to coma and death. And really all we're doing is supportive care and hoping they get better. If we think it's autoimmune, then they'll do the IV immunoglobulin. If it's herpes, they'll do a cyclovir. But most of the time it's just wait it out and we don't know what will happen. Reye syndrome. This is why we don't give aspirin to children who have a viral illness. This is a toxic encephalopathy. It has fever, profound impaired consciousness, and this is permanent. This becomes a permanent cognitive impairment. And then hepatic function. So the liver gets enlarged, full of fatty infiltrates. The brain, we have severe cerebral edema. They have high ammonias, so a decrease in the enzymes that convert ammonia to urea.